podcast. It's your co-hosts, Tom Hansel and your CEO, Chad Wurs. And we are here together today to have a celebration of the new year, the new quarter. We're excited about 2024 and all that it's going to bring. And we welcome our guest, Matt Noffsinger. And Matt, you've actually been on this podcast last year, so thank you for agreeing to come back and share a little bit of your time with us. I butchered the abstract last time that we talked, so I'm not even going to try to give one this time. Everybody's safer that way. But why don't you just start off by introducing yourself?
Yeah, thanks, Tom. Thanks for having me. I'm I've been in the pharmacy world since the late '90s, I guess, and I started working for it was a company called Sanyo at the time, which is now PHC, but it was all around pharmacy automation, and I've been in the pharmacy automation world my entire career, and I'm still in pharmacy automation, but I've diversified a little bit because I've been pursuing this passion project around helping pharmacies diversify out of script filling and trying to help them find ways of diversifying revenue. And I know that's something everybody on this call today is pretty passionate about. But I've been going down that journey now for the last year and a half or so, trying to actively participate in helping pharmacies do that and consult with folks to help them do that. So that's kind of where I'm
So,
at today.
someone that's been in the industry just as long as Chad and I, you've seen a lot of changes, and some of those have been good and some not so much. And we all just got back from the MHA
Yeah.
annual conference, and it was a lot of positives there. Good people with really good hearts and excited about the future. But there's also an industry that seems to be really stressed. What was your take from that meeting?
Oh yeah. It's interesting because you know, you've got the group of folks who are kind of buckled in for the ride, and it's not a fun ride. It's pretty bumpy. And then you've got another group of people who are saying, that mindset of with adversity comes opportunity. And those are the folks I think who are more likely to survive the storm as we go through these reimbursement changes and so forth that are hitting us. I think they're probably more likely to weather the storm. But I don't discount anybody. I had a gentleman tell me once, he said, he was he running his business a certain way. And I said, why don't you do it this way and that way? And he said, Matt, I've been doing this a long time. I make money. I know what I'm doing. I'm not going to change it. And so sometimes it's okay to put your head down and just and keep it at what you're doing. Um, but I do think in today's environment, there's an opportunity to do things differently and to make some investments and diversify away from this sort of tumultuous reimbursement environment that we're in right now.
Yeah, I think being at that meeting and really trying to read the tea leaves of this year and really, I would say for the next 3 to 5 years, we're going to be talking about reimbursement for pharmacy. I mean that's ultimately what needs to be impacted either legislatively or through regulatory, um, and it's all connected to pricing. We can do all kinds of things to decrease the costs that we have, and we can create some efficiency there. But the reality is, if the revenue's not there, it never exceeds some of those costs. And if you start pulling some of the um, profits that you gain from some of these higher dollar medications that have better spreads and rebates, you've got to find profit somewhere else. And it's got to come from being reimbursed fairly for the services that you provide. For way too long, we have been in this mindset. And I saw a couple things recently in the news that just sort of reiterate this mindset that it's okay for pharmacies to lose money or to have razor thin margins because we put them in the back of a Walmart or a Target, and the Walmart and the Target do fine, even though the pharmacy barely breaks even. We've done this to some degree to ourselves, and the model just keeps sort of replicating. The Amazon model isn't so much about providing good pharmacy to people through Amazon. It's about pulling more
Yeah,
Amazon
making them a
people to the
Prime customer.
Amazon site. I mean, it's the same model. It's the pharmacy in the back of the store. Like while you're on there getting your pharmacy from Amazon, they're going to pepper you with everything that you looked at the past week on your Facebook account, and they know
Yeah,
that you're
or the
interested in buying.
Walmart $4
It's
generic when they came out with that. It was just to get them in the store.
right.
Hmm.
Lost leadership.
And
So I think
now they've
this
got them in the store, but look what they're doing.
right.
Not only are they, selling them milk and greeting cards, but they're selling them healthcare services now. You look at what
Yep.
the retail chains are. I mean, they've invested heavily in trying to turn their pharmacy patients into clinical patients.
Yeah. Yeah. So I mean, there's going to be a lot of change. The IRA, the Inflation Reduction Act, and its impact on drug pricing is going to be a profound challenge for all of us to try to figure out how to navigate. I like, Matt, what you say. These pharmacies that do not run away from the problem but run into it and say, okay, how am I going to, these are the new rules, how am I going to make this work for me, are the ones that are going to survive. um, that doesn't mean that
And
we're
Chad,
not
what
going
I
to
think, what I
try.
like
Go ahead.
that no, I agree. What I like about, and not no not to make a shameless plug for ASCAP, but what you guys are trying to bring to the conversation right now, and you're and through these podcasts and showing people ways to think outside the box, ways to look at different revenue streams, and not just while you're also focused on reducing costs. Yes, that reducing costs is important, but I do think that ASCAP is on the right path here in helping folks engage in those different
Well,
revenue
first of
models.
all, we
Yeah.
like
And
shameless plugs, but secondly, uh, that really is kind of why you're on. Why he had you on the call today. It's really about diversifying revenue streams, looking outside that PBM, and you've been working very closely with clinical billing over the last couple years, and so I wanted to kind of dive into that and kind of understand what you define as clinical billing and what opportunities that you think pharmacists today that aren't clinical billing experts, that aren't the providers, but revenue opportunities that they can diversify for.
Well, I appreciate that, Tom. And Chad, I want to go back to something you were talking about prior to discussing that, which is that pharmacies are focused on lowering their costs, and a lot of times that comes down to, I need to negotiate a slightly better drug contract with my wholesaler. Does it move the needle? I don't know.
I
Uh,
mean, a little bit.
or I need to buy another piece of automation so I can try to save another half a tech.
Yeah. I
Does
mean,
it move the needle?
these
I don't
are
know.
these are things that all businesses should do, but to your point, they're not the thing. There's no one thing that is going to make that, focusing on your cost side is going to improve your profitability, but there has to be profit there to improve.
That's right.
So you have
That's
to
right.
get it on the reimbursement side. And what I like about what you're doing on today's call and what you're doing with billing is that we've always said, like, provider status. Everybody's waiting for this holy grail of provider status. It's coming in these incremental pieces. There's probably 5 or 6 ways pharmacies and pharmacists could bill and pick up some revenue for some of the services that they're doing, clinical and otherwise. But it's about understanding them, finding them, and implementing them the same way you would implement things on the cost side, the same way you would um, look at your automation, look at your logistics in an effort to make your cost side more efficient. Kind of see that on the billing side.
That's right. And Chad, you can control your cost side to some extent. To the
Yeah.
extent you can negotiate, you can operationalize, you can control that a little bit. You cannot control, unfortunately, we cannot control where reimbursement's going. I mean, we have some influence and we have great organizations in our pharmacy network, but you can't control that. What you can control is your cost to a certain degree, and you can control where you go get business. You can control the revenue side. And we need to start focusing more on the revenue side. It's been ignored way too long. And so, I I see people who I have the benefit of talking to every single pharmacy in the country and in Europe and Asia. So I see a lot of different models, and people are doing some really creative things to supplement their income. And it could be it could be compounding. Compounding has been a way that pharmacies have not only been able to market themselves with easier to take medications or with customized medications, but boy, they they come with a higher margin many times, and that's a business that pharmacy kind of left. Not everybody, but a lot of people got out of compounding a long time ago, and I could see that being a resurgent area for revenue opportunity. I can see vitamin integration, and you can go out today and find probably a dozen people who have software and algorithms that will help associate disease states and age categories with certain vitamin opportunities. And a lot of the people that you might be servicing in an at-home market or in an ALF building or otherwise might be candidates for that. So this isn't something where you have to go out and recreate the wheel necessarily either. Now, I think there's an opportunity for pharmacy, to your point, Chad, to work to the top of your license and go after the clinical side. And I like that component because it's not a commodity, it's higher margin, and you're really playing into the continuum of care for a patient. And I also think that the physicians would benefit mightily from having that partnership with pharmacy. Yeah.
And I like what you're saying because I think too often, especially in our world, you've got this sort of what we now call a traditional consultant pharmacist, which would be somebody that goes into the home and works with the medical team and does the drug regimen review. And then you've got what we would now call an operational pharmacist, when in reality, go back to the history of ASCP, at the very beginning, that consultant pharmacist was all in one. It was the community pharmacy that was probably servicing, retail, that was asked to help with the nursing home. And as part of helping with the nursing home, they created all the logistics and innovation and ways to speed up the process. And then at the same time, they helped the nursing home manage the medications that were going in and out of that nursing home, and eventually evolved on two different directions. One, clinically, evolved to the point where we have pharmacists doing MRR, and it involved, tremendously on the packaging, storage, handling, and logistics side. And that's really now what defines long-term care. And these opportunities for revenue come from both of those areas and some synergies of them being together. Whether you're an independent consultant pharmacist and you have a contract with the pharmacy or the nursing facility, you still have to work with the pharmacy
That's
to,
right.
to do some of this stuff. And
That's right.
I like what you're saying too about compounding and vitamins. And I would also throw into that, we need to go back and be pharmacists again when it comes to designing the med regimen for the patient. We have to be okay saying, hey, this type 2 diabetic that's on insulin, that is arguably troublesome because it's complex, it can cause hypoglycemia. They could be on this GLP-1 inhibitor that's one, or the
Absolutely.
GLP-1 agonist that's once a week, easier on the nursing staff, covered by the insurance. And yeah, it's expensive, but that's not my fault. You know what? The fact that we generate more reimbursement from that, I don't want to say it's not my fault as the pharmacy, but it's really not my fault. It's still what's best for the patient. If it were my dad or mom, that's the medication I would want. So we kind of have to go back to that mentality of, where's the margin from a pharmacy perspective? It's in vitamins, it's in compounding, it's in some medications that could be applied that are often resisted by certain, insurers or PBMs, but that we could have influence over getting on board with patients. And that's, we don't want to be tied to the product, but we still have to be tied to the product because that's the way we're reimbursed right now. So as we explore these outside things, we have to keep our focus also on the dispensing
Matt,
piece.
let's jump into some of those clinical billing opportunities. Let's get a little more granular.
Yeah, yeah,
Yeah, sure. I was just going to say, Tom, that I was at that MHA meeting. I had so many wonderful conversations, and some of them were, you know, we've tried to do we've tried to do things like follow patients home out of the nursing homes and rehab. And I kind of pressed on one gentleman, like, why didn't that work? I had two different conversations about this. One pharmacy said it was really hard, really, really hard. And then and the CEO of that organization said, I can't accept really, really hard anymore. We have to make this happen. I had another gentleman say, um, yeah, it failed. And I started questioning why it failed. They never dedicated a resource to it. So no matter what revenue stream you want to go after, you have to dedicate a resource to it. It doesn't mean it has to be a full-time resource, doesn't have to be an expensive resource, but you have to treat it as a business model. Who starts up a pharmacy and thinks that they can use their existing warehouse staff from another business or something? That's not how this works. You have to dedicate a resource to it. And I think that's why a lot of these things fail. It's just that you don't take the step. And if you do take a step, you don't treat it as a new business opportunity. And I think when it comes to clinical billing, Tom, I think that is a very critical component to all of this. Um, the you talk about the GLP-1 medications, that could be a whole business in and of itself. Now, can you get the allocation for the drug? That's a different story. But what resonated with me out of my meetings at MHA that I just came from was when people have had success, it's because they dedicated a resource to work with their drug wholesaler, to work with their physicians, to create a network that helps create that allocation that you need for that GLP-1. It's if you have a pharmacy, I worked with a pharmacy in the center of the country doing remote patient monitoring. They didn't just go out and implement remote patient monitoring. They got a collaborative care agreement and they went to the payer and they went to the state and they got the payers on board with their patient set by proving the outcome benefit, the benefit of outcomes with those payers. But that's the kind of concentrated effort that we need to be pursuing as an industry to help us bring those new revenue opportunities on.
yeah. Well, and we talk a lot about vaccines, especially since the pandemic, but
Right.
it's exactly that concept that you just brought up, applying resource. Like we can sit here and say every older adult in a nursing home really requires 3, maybe 4 vaccines every season. If you just use general terms, you get paid $30 to administer it. You're going to make arguably 10% spread on the cost of these vaccines, which are all now higher priced than they used to be. The flu used to be, $20 a dose. Now it's 130. COVID's 130. Pneumococcal higher than that. RSV's, 250. Like if you start thinking about a 100-bed nursing home, you've probably got 125 to 150,000 in revenue and about 20% profit in a vaccine clinic. That's in one nursing home. So to your point, are you going to apply your resources and invest in that? If you're a small pharmacy and you have 10 nursing homes, you're talking about $1 million in revenue and a couple 100,000 in profit. And yeah, you're going to have to spend some effort coordinating and maybe even using some of your labor to administer. But what other drug product or what other thing you're selling generates that kind of return? And that's low hanging fruit, but you got to do it. And there are efficiencies there. Every one of your nursing homes has a consultant pharmacist that goes there on a periodic basis. They might not go there more than once or twice a month, but again, if you're coordinating and you're thinking about this, could they go there more often in order to support a vaccine program so that it has low labor cost that you're just coordinating to maximize that potential profit? I mean, there are just ways to look at this. Contracting with the nurse. ways to look at this that can make it so much easier.
Yeah.
But
Chad, Tom, have you guys ever heard of anybody doing shingles vaccines
right,
alongside their flu
right.
vaccines? Right, like
They should be doing all of them. All of
right.
the ACIP approved older adult vaccines. That should be, again, I don't want to say that when I say this, that the pharmacy should be responsible. A lot of people take that as you have to do it. Oh, that's so complicated. How am I going to get people there? That's not what we're saying. We're saying you should be responsible for it, meaning you should bill for it and you should generate the revenue and reimbursement for it. You can contract with the nurse that's in the nursing home to be the last mile and stick it into the arm, but you can mediate that with the reimbursement that you're getting. You can share some of that administration fee that you bill for with that nurse that's actually putting in that injection into one of the patients. And you can also have a program that is flexible enough that, hey, in September, I am going to send my pharmacist and technician into the home because we're going to do 300 vaccines. And then for catch up, I'm going to use the nurse at the nursing home when I only need one or two done. Like build a platform that generates reimbursement and profit. And I don't want
Yeah.
to spend too much time on vaccines because you do much more than that. But it's just an
No, it's
example.
good.
It's an
It's a
example
great
of
example.
what we need to
So
be thinking
you got
about and doing.
absolutely, and not enough pharmacies, long-term care pharmacies are doing that. You got vaccines, you got MTMs on the retail side, but again, let's dig a little deeper. What
Yep.
other type of clinical billings, non-PBM dependent type of clinical billing could we talk about?
Yeah. So, today you can do transitional care, you can do annual wellness visits, you can do all those sorts of things. And I think those are under underutilized by pharmacy today in and of itself. However, I mentioned earlier, Tom, remote patient monitoring. Um, I'll use now remote patient monitoring, or let's talk about pre-diabetes. So if we know that someone has just been diagnosed with pre-diabetes, there's a whole bunch of billing code opportunities underneath that just dovetails. So if you get an ID, an ICD code, a diagnosis code of pre-diabetic, if you know that information, that core piece of information, you can go out to Codify, you can go out and look up what all the other billable opportunities are. And one example of that would be smoking cessation. It's a CPT code billing opportunity under that ICD code. Well, it turns out a lot of physicians aren't actually providing that service for smoking cessation. If that's something pharmacy can identify, it's no different than doing diabetic education in your pharmacy. I went into one pharmacy where they had an entire counseling room set up, and they brought the local population in and offered classes on disease education. I went to another guy who had 3 electronic terminals set up, and you can just walk up to an electronic terminal and watch the video. You log in, watches the video, it records it, boom, billable event, no pharmacy staff involved. Those types of really creative things can be done. Many times it has to be done under a collaborative care agreement. But I have never, like, as I started getting into the operations of pharmacy, I had this revelation one day where I was sitting in the pharmacy and we were observing the billing techs and the onboarding techs, and I'm listening to this gal. She called a physician's office and had probably a 15-minute conversation with the physician about listening to talking about a patient who was complaining because she wouldn't take that med in the morning because it made her stomach sick, and the physician rewrites the scripts and pushes it to another hour of administration. And I'm like, wait a minute. These people have these incredibly powerful relationships. And I'll bet you $1 if you went out and asked them for a little bit of data so you could help them do their jobs better, you've probably got a pretty good chance at it. And if you do a collaborative care agreement where you become part of that actual continuum of care with the physicians, and you're both benefiting financially as well as under star ratings and outcomes, I think there's a major opportunity here, guys. And and not because Matt thinks it, because Matt has seen it work on a very limited basis. There's very few people doing it, but
And we
it's
already
it's a
have these
model that
patients in the
works.
long-term care
Um,
center, and we just let them go away because we don't want to go after that retail or the at home. But there's a good example of being able to, you already have that captive audience, you already have that relationship, you already probably have the data and their disease states and how to continue not just dispensing the medications, but things like this.
Diversifying your revenue, and you made that comment, Tom, about you already have the patients. So let's look at our long-term care market. They're all out there fighting for the same 100 beds
Swapping
every
back and
year.
forth.
Maybe you got it, maybe you didn't. They got bought by somebody, they got rolled up into a national chain, whatever. And it's so frustrating. Yet you have your patients. So how do you monetize those patients in various ways and bring revenue? That's number one. Number two is, especially if you have a skill building and they've got a rehab component to it, even if you've only got one skill building with a rehab in it, all those rehab patients are leaving every 4 to 7 days. So do the math on that. Let's say you got 20 rehab beds and they leave every 7 days. That's 28 patients a month. Say you get half of those, it's 14 patients every month that you add. In a year, you added your 100 and 150 beds.
Well, use the big numbers. Like there's 1.7 million nursing home beds, but we know that 4.2 million people put their head down in one of those beds every year. I mean, there it is right there. Like you're walking away. If you let that person walk out, you're always going to have somebody in your 1.7 million beds, but you're letting 3 million people walk out the door, but walk away from your
Once they get
pharmacy.
home, so we're kind of pivoting away from clinical billing a little bit
Yeah,
in
we
our
are.
conversation, but the grand picture here is creative ways of monetizing patients that you have already they're already your customers. You don't have to pay any money to onboard them. They're already your patients. The investment is in working out the SOPs to efficiently monetize them in additional ways.
Yeah, one of the things that I learned, one of the hardest things to put your hands around when you get in the association space is the pharmacy health, um, pharmacy HIT, the technology piece. And I was sitting in a meeting. This was before COVID, so this is how long ago it was. It was more than 4 years ago.
Hmm.
But CPESN, which is a network of community pharmacies, was was pushing to get reimbursed along blood pressure. So when they would refill a blood pressure medication, they could also inform the payer of the person's blood pressure. Either they took it in one of the machines in the pharmacy, or they took it with some of their labor, and they would report the blood pressure as an indication of, hey, we're paying attention. We want to help control their blood pressure. And they're getting paid to do that. They're literally getting paid to report the blood pressure at the time the person was in the pharmacy. And the numbers that they were talking about then, they were like, we're doing about 4,000 of these claims a month. Me being fresh out of a consulting business where I probably carried 600 or 800 beds myself, but the pharmacists that I work with are all carrying about 1,000 beds. I'm like, we could submit 100,000 blood pressures a month just from my little company. Imagine what the pharmacies could do, these 10,000 bed pharmacies, these 5,000 bed pharmacies, if they could link the data that the consultant was collecting with the dispensing data that they were doing and apply that same model to it, report that information to that payer that has decided that, yeah, we'll pay you to find out how well we're managing that patient. The payer doesn't know the difference between somebody in a custodial side of a nursing home or somebody that lives in their house. They would reimburse for those services, and that's just blood pressure. What if we did hemoglobin A1Cs and all the other information that we have access to in long-term care that we don't in the community setting? But you got to figure out how to participate in that activity. And that was the
Chad,
point where COVID entered and we got distracted.
Chad, that's an amazing point you just made, because I work with a physicians group right now on a clinical billing project. And of course, blood pressure is obviously in their top 10 billable items that they get paid for.
Yep.
And we're seeing those people all the time. Now, my proposition is that if you have a polypharmacy, complex, multi disease state patient, and they go home out of your facility, you should be all over those patients to continue monitoring them. And whether that's them walking, maybe they're not going to walk into your closed door pharmacy, but with a simple Bluetooth device, you can be accumulating all that information on that patient. It makes you sticky with the physicians. It gives you a revenue opportunity. If you figure out that model, which may not be that attractive if you've got to put a Bluetooth device out, and maybe that's a little scary, but it helps. But that is the beginning of expanding your clinical billing operation within a patient set. And once you do a Bluetooth blood pressure cuff, and you've got a diabetic patient, it's not that hard to do a Bluetooth blood glucose.
Right.
It's not that hard. You can expand, spirometers, all of that stuff. You can be passively accumulating data that can bring you revenue, but also make you very sticky with the patient and the providers.
Well, and again, thinking of it in terms of a long-term care pharmacy, assisted living, they all live in the same building. So when you were talking about kiosks and educational group settings
Yeah, good
and
point.
collecting that kind of data, you don't even have to necessarily give somebody the Bluetooth as an
Yeah.
individual. You could give them, you could set up a machine just like a pharmacy does in their pharmacy in the dining hall of the assisted living facility and ping them to make sure they check it periodically.
And I'll bet you if you go to Google, and I haven't done that, but if you go to Google, you'll find a dozen companies that do
Yep.
this
Yeah.
today.
And that really comes down to also adherence, obviously, even at home device for helping with adherence or
Yep.
adherence packaging. And, that's what, we talk about to no end. But the reality of it is adherence to medications decreases rehospitalizations. But then you throw in all these other monitors
Yep.
and able to, track their disease states and their signs and symptoms, then you certainly can decrease rehospitalizations that much more.
So as an industry, and I think I've said this on the previous podcast, but as an industry, I get frustrated because you've got all these associations, and I feel like oftentimes our associations are arguing for things that are very difficult to impact and control. But if we were lobbying the payer sources, Aetna or Blue, the Blue programs, whether it's regionally, locally, regionally, nationally, if we can bring them along with the idea that under collaborative care agreements, we are going to be deploying remote patient monitoring, drug delivery systems at home, or even in an ALF facility where it's easier to deploy, but you're getting data back. Those are ways that actually meaningfully impact patient outcomes while generating revenue for pharmacy. And I feel like those are the types of things that we can control. And those are the fights that I personally have been engaged in and want to help pharmacies work to.
Yeah, absolutely.
All right, Matt, I appreciate your time with us, but we know that you're a big Abraham Lincoln fan, and you get a chance anytime
Oh,
you can
that's
talk
right.
about Abraham Lincoln, you get a chance to do that. So I want to ask you if you have some fun facts that none of us common folk know, but true Abraham Lincoln enthusiasts enjoy talking about.
That's an interesting question. Well, I'll tell you this. Abraham Lincoln was suspected, pharmacy related, was suspected of having syphilis. And it was speculated that he got that by visiting a woman before he got married when he was in Springfield, Illinois. And so he started taking a drug, they called it blue mass. um, but it was really just a form of arsenic, really, or I'm sorry, mercury. So he would dose himself with mercury. He was slowly poisoning himself to death, which drove him into Great Depression and also really bad health conditions. And it made him very angry. And he didn't like being angry, so he had to wean himself off of the blue mass pill. So that's my Lincoln Pharmacy story for the day.
That's pretty
I
good.
hadn't heard that.
I like that.
I thought you were going to talk about the fact that he used to be
Yeah.
a wrestler and won all those matches or something of that sort, but I like the tie in the pharmacy. Yeah.
Well, see, you already knew that,
I was
so
prepared
would have been a
just in
fail.
case.
I don't know if we said this last time you were on, but in DC, one of the cool places to go is Ford's Theater and see a play at Ford's Theater. They still do plays there, and they have a whole Lincoln museum underneath the theater that you get access to when you get there before the show starts. And they have the gun. They have the gun there that John Wilkes Booth used to assassinate Lincoln. It's
I guess
fascinating.
Matt's a
All
regular
that stuff is
member
fascinating.
there and probably goes about once a month.
I bet he is. I think I saw it on my chair when I sat down that was the Matt Noffsinger chair.
I gotta be honest with you. I feel like the whole death part of the Lincoln story is my least favorite, obviously, although it made him a martyr and made him, what he is today in American society. But I I was always more inspired by early Lincoln and how he got through adversity. And I always looked at him as an inspiration because he was always fighting through whatever adversity he has. And I think it's a good note
That's
for
right.
our pharmacy
Yeah.
market today too.
Yeah. Well, and that's one of the things I really like about that museum is when you first walk in, it basically starts the conversation when he returned to Washington following the Gettysburg Address. So the first section of the museum is all about how the press was ridiculing him and creating political cartoons about him, and it just gives you some sense that you try to compare 1860s to today, and you're like, it's still like that, but maybe it's always
Yep.
been like that. So maybe it's okay.
Most people are celebrated
So
after they die. So.
interesting. Yeah, it's always been this way. It's always been this, media firestorm.
It really has. It's always been just brutal. Another little interesting tidbit about Lincoln is um, he was actually challenged to a duel for trash talking a political opponent in his early political career, and so yeah, he was no saint. He played all the games that they play today.
That'd be actually kind of
Absolutely.
fun to let the political opponents, have to wrestle or play basketball or something, right?
I mean, I think all of us would
That's
take.
right.
I think all of us would take the duel.
For sure. Well, Matt, anything, I appreciate the time you spent with us, and really the point is that there's a lot of other ways that you could grow your baseline, grow the net value of your company, and grow your bottom line beyond just prescriptions and beyond just getting reimbursed and being kind of captive to the PBMs. And so I think there's a lot of good opportunity out there. If you were a pharmacy, where would you start at? What would be like the first one or two things that you would do or advise pharmacies to do that we can leave them with?
Well, in the world of clinical billing, I would start a relationship with my physicians. I would leverage the relationship with my physicians and start asking for data because data is power. Whether that's manually retrieved or whether it's electronically retrieved, get the data, and then you can start leveraging it. And pick up the phone and call folks like you and Chad and myself or others in the industry who have done this, who've seen it done 100 different ways, and just pick a path, take a step.
It's awesome.
Well, thank you for your time, and I appreciate it. Looking forward to seeing you at the next
Yeah,
conference.
thank you guys for having me. It was fun. I enjoy it.
That's right. At the next conference, I know our conferences, our regionals are starting in April, but we'll see you around.
All right, guys, we'll see you.
Bye.
Thanks for having me.
Thanks, everybody. We'll see you on the next episode of Our Experience.